Hello and welcome to my channel. This lecture we will be discussing the anal triangle and the anal canal. So let's begin. In the last lecture we studied the boundaries and fascia of the urogenital triangle. Today it's the anal triangle. We will start by discussing the perineal body. The perineal body, which is the area between the rectum and the genitalia anteriorly. It's this area, the perineal body. It's fibromuscular node apex at the rectovaginal or the rectovesical septum in males. Now, the structure attached to the perineal body from above downwards are the levator prostatae muscle, or the pubovaginalis part. Remember when we discussed the levator ani, the deep transverse perineai and the sphincter urethrae, and the deep part of the external anal sphincter. Then the bulbospongiosus and superficial transverse perineai and the superficial part of the external anal sphincter. These are the structures attached to the perineal body from above downwards. The fascia and muscles of the anal triangle, the superficial fascia, it's a fatty layer, thick areolar adipose tissue, extends to the ischiorectal fossae. These are the ischiorectal fossa on each side of the anal canal. The deep fascia lines the ischiorectal fossa, lines laterally the obturator fascia and the inferior fascia of the pelvic diaphragm. So I mean the fascia lines the whole thing, the whole walls of the ischioanal fossa or ischiorectal fossa. The ischioanal fossa or the ischiorectal fossa is a wedge-shaped space between the apex. Apex is at the meeting of levator ani and obturator internus. The base is towards you. You are looking at it right now. The boundaries, the medial boundary is the external anal sphincter, inferior fascia of the pelvic diaphragm, because the levator ani descends in an oblique fashion this way. So medially is the wall of the ischiorectal fossa. Laterally is the obturator internus and fascia and the ischial tuberosity. Laterally. Posterior is the inferior border of the gluteus maximus and the sacrotuberous ligament. Anterior is the urogenital diaphragm, which is the sphincter and the deep transverse perineal muscles, and the space extends above the urogenital diaphragm anteriorly as the anterior recess of the ischioanal fossa or ischiorectal fossa till the back of the pubis. Now it's connected posteriorly at the external anal sphincter and the internal pudendal vessels and nerve, and the pudendal nerve traverses present in the lateral wall, and the branches traverse the ischiorectal fossa, as you can see here. See, these are the internal pudendal vessels and nerve, and these are the inferior rectal branches and the perineal branches traversing the ischiorectal fossa. So these are the boundaries and contents of the ischiorectal fossa. Now the fat in the ischiorectal fossa, together with the perinephric fat, remember the perinephric fat we studied with the urinary organs, are the last fat to be consumed even in starvation. The body consumes this fat at the very end, not in the beginning of the need for fat cells. Okay, the anococcygeal ligament, this ligament is a median stratified musculotendinous structure between the anorectum or between the anal canal and the coccyx. The layers are the pubococcygeus are above, then comes the iliococcygeus and the posterior attachment of the external anal sphincter below. So this is the anococcygeal ligament we mentioned in the insertion of the different parts of the levator ani muscle and the external anal sphincter. The anal canal itself, it's a continuation of the rectum, ampulla of the rectum to be precise, descends down and backwards, as you can see here, for about 4 centimeters till it reaches the anus, which is the external aperture, external opening of the anal canal. Anteriorly, it's related to the perineal body. See that? Separating from the urethra, bulbous urethra of the penis and the lower vagina in females. Posteriorly, it's related to the anococcygeal ligament. Laterally are the ischianal or ischiorectal fossae, and it's surrounded by the anal sphincters, as you can see here. Okay, so remember, anteriorly it's related to the bulb or the lower vagina. Why I am stressing on this? Because this is what you feel in the digital rectal examination. The very proximal parts are the bulb of the penis and the lower vagina in females. Posteriorly related to the anococcygeal ligament, laterally to the ischiorectal fossae, and it's surrounded by the anal sphincters. About the lining, the upper half is lined by mucosa, red in color, because it has an internal rectal venous plexus beneath it, submucosal I mean, and the lining is a simple columnar epithelium like the rest of the GI. The mucosa shows about 10 vertical folds, the anal columns you can see here, the anal columns. Each column is raised by a terminal branch of the superior rectal vessels, either the beginning of the vein or the end of the superior rectal artery. Remember that. And the largest columns of these are present at the direction of 3 o'clock, 7 o'clock, and 10 o'clock. So one right anterior, right posterior, and left side columns. Why we are mentioning these? Because these biggest columns are the sites vulnerable to be affected by a hemorrhoid. So you commonly find the hemorrhoids at the direction of 3, 7, and 10 o'clock. Okay? And it's also a site of portosystemic anastomosis because we mentioned that these are the superior rectal vessels descending, superior rectal coming from inferior mesenteric, so the drainage will be to the portal vein, and below that it goes to the inferior rectal, means to the internal pudendal and internal iliac veins, means systemic veins. So this is a site for portosystemic anastomosis, and hemorrhoids develop in the case of liver cirrhosis, for example, any case in which there is increased portal hypertension. The lower ends of the columns are linked by mucosal folds. You can see these folds. These are called the anal valves or pockets, and together they form the pectinate line. And this is the remnant of the anal membrane. There was a membrane before, and it degenerated. Sometimes it doesn't and produce a problem in passing feces in newlyborns. So it's treated by simple excision. Above each column is a small depression, which is the anal sinus. So we have anal columns, we have anal valves, and we have anal sinuses. differentiate between these structures. In the sinuses opens anal glands and submucosa in the submucosa. And in these pockets, the anal valves, hardened feces may lodge inside the valve and cause infection later on. This infection leads to anal fissures. Anal fissures are commonly caused because of continuous constipation and dry feces that lodges in the pockets of the anal valves. The lower half of the anal canal or of the lining is the pecten, and it's a transition zone from simple columnar to stratified columnar keratinized, that is the skin. So the pecten is lined by stratified columnar non-keratinized epithelium, and it's the transition zone between the inside and the outside. The submucosa contains dense connective tissue. Okay, the pecten, the one we were talked about now, ends at what's so-called the white line. The white line you will find here is simply the groove between the internal anal sphincter and the external anal sphincter. It's the intersphincteric groove. The intersphincteric groove. Below this line or below this groove is true skin. Skin that has sweat glands. Above the anal valves, here in this area, this is the site we inject for hemorrhoids, especially if the hemorrhoids were not descended to the lower part. It's a silent hemorrhoid or non-painful hemorrhoids because it's the pain here is carried by visceral supply, not by somatic supply, which is more sensitive to which if the hemorrhoid reached this zone, it becomes painful, okay, in the pecten area. So above this line is above the line of the valves is the site for injection of hemorrhoids, and here in this site the hemorrhoids are not painful, not like when it descends to the lower part. Now, remember the pubococcygeus, it blends with the longitudinal muscle layer of the rectum and forms a longitudinal fibrous coat. You see this coat? It's called the fibrous longitudinal coat. Descends between the internal anal sphincter and the external anal sphincter, and then it divides into a series of septa, as you can see here, going to the skin, forming what's so-called the submucous, the perianal space. This is the perianal space. This is the fibrous longitudinal coat, dividing into septa, lower down, see that? Forming the perianal space. This perianal space surrounds the anus. So if there is pus inside or infection starts or perianal abscess spreads in a circular fashion around the anus because it's limited by the fibrous septa of the fibrous longitudinal coat. Also, contents of the perianal space are the subcutaneous part of the external anal sphincter. This is the subcutaneous part. The corrugator cutis ani muscle. It's a muscle to corrugate the skin around the anus. The external venous plexus with its junction with the internal venous plexus. External venous plexus means it has the terminal branches of the inferior rectal vein, and it has also compact fine fat between the septa of the perianal space. The space, as I told you, is limited, and if infection develops, it's very painful and spreads in an annular fashion around the anus. when examining from the outside. Okay, the submucosa has the submucous space has the internal anal venous plexus. So we have the submucous space and we have the perianal space with its contents. I hope you got this arrangement. It's important. Remember, the fibrous longitudinal coat separates between the two sphincters, and then it divides into septa and forms the space, the perianal space lower down around the anal orifice. Okay. The muscles, the anal muscles. We have the internal anal sphincter, which is in the submucosa, and it's a thickening of the circular muscle layer of the rectum. This is the internal anal sphincter, and it surrounds the upper 3/4 of the anal canal, as you can see here. See that? The internal anal sphincter. The external anal sphincter, on the other hand, is a skeletal muscle. So the internal sphincter was a smooth muscle, thickening of the circular muscle layer. External anal sphincter is skeletal muscle, voluntary muscle, and composed of 3 parts: the deep part, superficial part, and the subcutaneous parts. Deep parts, superficial part, subcutaneous part. The deep part blends with the puborectalis, as we discussed before, and attaches to the perineal body and the anococcygeal ligaments, and surrounds the upper part of the or forms the upper part of the external anal sphincter. The superficial part is the only part that attaches to bone, means the attachment extends to the coccyx at the back and attaches anterior to the perineal body, and it surrounds the lower part of the, or forms the lower part of the external anal sphincter. The subcutaneous part is transverse, as you can see here when it contracts, and it's below the internal and below the superficial part, and attaches to the anococcygeal ligament and the perineal body as well. So we have deep part, superficial part, and the subcutaneous parts. Skeletal muscle, the external anal sphincter, different than the internal anal sphincter, which is a thickening in the circular muscle layer of the rectum around the anal canal. Now, above the anal valves, the nerve supply is by autonomic nerves, and the blood supply by the superior rectal vessels, the artery and the vein, and the lymphatics to the internal iliac lymph nodes, this area. Below the valves, which is the pecten, the nerve supply from inferior rectal nerve, which is a somatic nerve, a spinal nerve, and the blood supply is by the inferior rectal vessels, so these are somatic vessels, and the lymphatics to the superficial inguinal lymph nodes. So see a big difference between the lower part of the anal canal and the upper part of the anal canal. Remember, the upper part is the visceral part, the lower part is the somatic part, which is the pecten, and downwards till you reach the anal verge. Now, in excising the rectum, the section must be close to the wall as much as possible, so not to cut the autonomic nerves that skirts around the rectum and the anal canal. This will lead, if they were injured, this will lead to bladder dysfunction and impotence. Remember that as a complication of pelvic surgery. Also, the urge sensation carried via parasympathetic supply, but the pain sensation carried in sympathetic supply and parasympathetic supply. Okay, so this concludes our discussion about the anal triangle with its contents, like the anal canal. I hope you got the maximum benefit from this lecture, and thank you very much for watching.